So thank you, Susie, and Turning Point for the invitation. Much of what I'm going to do is really give a clinical reflection on much of what you've just presented, Susie, coming from a clinician and a frontliner. I need to declare I have done some advisory work for the pharmaceutical industry with regards to GP education, and one of the big issues we have is accessing GPs, and we potentially need to do that in part through the industry because they are already accessing them and we need to have influence on what they say. My personal journey is influenced growing up in the country. I did work experience with a vet. He used large dose of ketamine plus medetomidine for gelding horses in the paddocks. And I thought that was interesting, and we've actually gone away from that as a veterinary practice, but it's starting to re-emerge in anaesthetic practice. I then went on and became an anaesthetist, and early on in my career in hospitals, we were using buprenorphine sublingual for post-operative analgesia. Then with the push to shorten length of stay in hospitals, we moved to oxycodone. So moderate or PBS limited dosing for shortened length of stay to get people managed in their pain relief post-operatively became common in the 80s and 90s. In addition, there was a major clinical trial on epidural analgesia which didn't show effectiveness. So our frequency of using regional analgesia fell away and we increased our use of opiate anaesthesia. And lastly, remifentanil and some of the really potent opioids came into practice in anaesthetic practice and then post-operative practice because it blunted the hemodynamic response. Then in the community, pain medicine started to use OxyContin specifically, which had specific pharmaceutical, pharmacokinetic and dynamic issues as to why it was so potent in developing opioid dependence. And this was, I think, one of the leading issues in America, and it was an abuse deterrent. It was not an abuse deterrent formulation, it was a large dose of something that could be easily accessible intranasally or intravenously. And now, coming full circle, as a clinician, we're dealing with the political response to the opioid crisis, and I'll try to expand on that further. So as an anaesthetist, we know that nociception is tissue activation. So to have surgery, you will receive an opioid. We learnt with cardiac surgery, high doses of opioids blunt the heart rate, blood pressure response and lead to improvement in safety. So high dose opioid anaesthesia became normal. We also know, however, if we failed to give the anaesthetic appropriately, large activation occurred in the emotive areas of the brain and the evaluation. So anyone who missed out on their anaesthetic from a sleep perspective had high levels of distress. So the distress that we see in people experiencing pain has a neurological basis. And there was a study just yesterday published looking at the changes that occur in the frontal lobes of patients and prefrontal areas of patients with chronic pain. Their brain changes if you suffer pain, and distress is part of that. Clinically, we see it as upregulation of the peripheral nerves, we see it as upregulation in the spinal cord, but also at the brain level, and that we have this cohort of patients who develop persistent pain. So not all patients having persistent pain become distressed, but it's a high percentage. And this is the cohort that unfortunately had been started and managed with opioid anaesthesia, opioid analgesia. One of the other things we've found more recently is that these factors, the social factors and the thinking and the catastrophizing can change the neurological response to pain and exacerbate the experience of pain and lead to further changes at the brain level. And these factors are just as important as the severity of pain. So whether you've got catastrophizing, whether you've had trauma in childhood, the parental style that you grew up with have an influence on the risk of having chronic pain. Compensation systems, we've heard the report on work cover in Victoria came out and was discussed yesterday on radio regarding going through that process increases the experience of pain and can then increase your risk of having pain persistence or chronic pain. Perceived injustice is a very interesting issue coming through in the workers' compensation TSC space, where that experience of what's the cause of the pain influences the experience. There is evidence of better pain control early, including opioids, can improve pain control and lead to reduced opioid use long term and reduce pain long term. The other thing about having pain is that high incidence of depression, 40 to 50% of people with persistent or chronic pain report depression, high risk of suicide, between 2 and 3 times, and in some reports, if it's severe pain, up to 5 times the risk of suicide. So we're crossing here with Susie Nielsen's work on who dies from opioids, pain patients with high levels of psychological distress, high rate of suicide. They have access to opioids because they have pain. Also, the American evidence out of the Iraq veterans is that those with high levels of anxiety or post-traumatic stress disorder have a much higher rate of opioid prescribing and consumption. So some patients use their opioids to manage their anxiety or their psychological distress, or they're not having their psychological anxiety distress managed appropriately, so their opioid doses are escalated. So how do we as a clinician change that? So we've changed our approach to how we assess a person with pain. We really start at who they are. What's their neurological status like before the onset of pain? What's their social situation or education status? What are the psychosocial factors contributing to their pain experience? Then we look at the mechanisms. Is there nociception coming from tissue trauma? Is there nerve injury? And how much sensitisation has occurred? What's been the impact? Because really we should be about reducing impact rather than necessarily reducing doses. And then what's the expected journey? So that we can earlier intervene in those at risk. And then we do intervene along the lines of patient education to reduce perception of pain at the cortical level, pharmacological approaches. Opioids really are there for nociceptive pain, and they're anti-nociceptives. Non-steroidals are there for inflammatory component. The nerve drugs are where there's a lot of nerve injury or upregulation. Where do cannabinoids fit? And most of the pain clinicians would say there's no role for cannabis, but some of the emerging evidence would suggest at a brain level it's about perception and the frontal lobe and decreasing distress and anxiety associated with pain, not necessarily the sensory experience. So opioids, they are anti-nociceptive and they really should be limited for nociceptive pain. Reasons for failure that we've come on this journey are 4 main groups. First is opioid-induced hyperalgesia, so opioids sensitise someone, and codeine is a particularly potent sensitiser, and over-the-counter codeine was in part removed because it was causing harm by exposing people to low-dose codeine, increased their potential to have severe pain and poorly responsive pain when they then had an acute injury. Tolerance develops, disease progression or mechanistic change. So more sensitisation in the disease process of persistent pain meant they became less opioid responsive. And then you had the psychosocial factors of anxiety, misuse, addiction and diversion. We should be co-prescribing anti-hyperalgesics to prevent the tolerance and hyperalgesia with opioids, and we should, as a clinician, have preference for the atypical opioids with a dual mode of action. There are varied interpretations, and I'll pass through this, about the risk of addiction if you're acutely exposed to opioids. If you have no risk factors, the risk is likely to be less than 1%. The problem is, risk factors for chronic pain have similar risk factors for addiction. And so the cohort who develop chronic pain are the cohort that are at risk of developing opioid dependence and addiction. So up to 5 or 6% will develop if they've got risk factors, and potentially up to 20% of patients with chronic pain have some form of opioid dependence if they're managed on opioids. However, there's also evidence that showing using opioids appropriately improves outcome, and that is also relevant in people with nociceptive pain over the longer term, and this study was quoted as showing lack of benefit, but if you reinterpret it, it shows some benefit in the subgroup with nociceptive musculoskeletal pain. I'll move past that in place of time, and I'll move past this, looking at our preference as a pain clinician and in the post-operative period is the safer, theoretically safer opioids, buprenorphine and tapentadol, are becoming more relevant because they treat both the opioid responsive pain and the sensitisation component, and they may have safety benefits. So then part of the response. So we're responding to this, and these are the headlines as Susie has presented. And this is the atlas looking at the prescribing rates for opioids. And as part of my role at Royal Melbourne, we do some telehealth into Mildura and Hamilton and Western Victoria region, where they have a significant opioid prescribing issue. In some group, there's a socio-economic drift out of Melbourne into this group because they're stable, they're on high-dose prescription opioids, they're on support payments, they can't afford to live in Melbourne. There is very little access to heroin in those outer regional areas, and so prescription opioid prescribing per head of population is higher. And the overdose rates are also matching that prescription, so unintentional drug-induced deaths match to some degree that distribution. Of some interest here is the rates of colonoscopies per head of population is the direct opposite. It's 4 or 5 times higher in Kew than it is in Western Victoria. So there's socio-economic and health service factors at play here. It's not just about prescribing practices. This is expanding on what Susie has presented, looking at who are the people in the reports. And so these are the 3 most recent reports, and they're all talking about, well, what's that suicide rate, or who are these patients and how they're classified. So in the ABS data, 16% were classified as suicidal. In the Turning Point data report, 28%. In the Monash Hazard report is from September, looking at unintentional, these are non-deaths, but these are emergency department presentations, and again, high rates or higher percentage of self-harm. I'm looking at through these 3 groups. I see 3 clinical cohorts, those that have pain and distress and are managing that distress on high dose of opioids, and they accidentally to some degree can over-tip and they end up as part of a statistic. There's a group that have mental health or predominant mental health issues who do self-harm, and then there's a group who are younger males generally who are more drug dependent and are accessing prescription opioids. So what are some of the responses in hospital? This is one response which is coming from the anaesthetists. So we're actually starting to use more dexmedetomidine, which is a derivative of that original veterinary practice of using medetomidine. We use more ketamine, and we're using less opioids intraoperatively. We're doing advanced recovery pathways to limit opioids. We're doing a program for post-operative opioid management and trying to limit the dispensing of opioids, and are conscious of opioid prescribing out of hospital. And we're also looking at our internal activities. So internal activities are what we're dispensing, but also looking at intensive care. So this was an intensive care audit. We have 1 patient a month through our intensive care who have had an overdose of a prescription opioid. So they didn't make it onto the statistics, but we weren't managing them in hospital very well at all. Over 50% of these people were discharged on opioids. This is the Prince effect. Prince presented multiple times with opioid overdoses, but he didn't get healthcare intervention. These patients who are ending up on the statistical page are in the healthcare system, but our healthcare system doesn't necessarily respond well to them. We're doing stewardship programs to try to get early access, but again, getting a business case up and running and funded for such is difficult. And then of course we're doing SafeScript. Major investment here in SafeScript, and the concern is, well, this is a surveillance tool. It's really a clinical decision-making tool, and the message is it's to support GPs in their prescribing. GPs will not be able to, or other prescribers, not be able to say, I wasn't informed of patients who are getting other drugs, because this will become mandatory as of next year. It works by collecting both dispensing data as well as prescribing data, and having an alert system so that you are alerted to it. It uses the highest risk drugs, so toxicity levels of greater than 100 deaths associated per 100,000 scripts. So tramadol is not on it at the moment, and neither is the gabapentinoids, because it doesn't meet the criteria for associated deaths, because they're both reasonably safe in higher dose. What's not safe are the benzodiazepines, quetiapine and the opioids, and particularly in combination. There's a number of education tools with that. It will become mandatory, but there's not a great deal of legislative power to prosecute if you don't use it. And that's done for a reason. It's really meant to be a support program rather than a prosecutory program. Our concern would be that GPs will see the alerts and deprescribe rapidly, and we're trying to prevent that because of the potential for harm. So the big alerts are those that statistics tell us, which are the high drug combinations, so the dosing and the combination of benzodiazepines or other sedatives with the opioids. This is being integrated into GP pharmaceutical software and management software. We're working with the major public hospitals to have some form of integration of SafeScript into the hospital pharmacy systems so that you will be able to check reasonably quickly or even behind the scenes check and be alerted to data from the SafeScript system. And this is what it looks like. There's some new aspects to it about alert history and having access history. And this is where the department will be able to, and the coroner potentially will be able to detect, is if you've done a prescription but you haven't checked. And so it will change behaviour because it exposes prescribers to risk. So if their prescribing is risky prescribing and patients are at risk, there will be a trail, electronic trail, if they reviewed the data systems. So the problem is the adverse outcomes. So Susie's already mentioned the issue with increasing risk of death in the American data. There's also a clinical phenomena of rapid opioid detox or reduction leading to agitation and anxiety. There have been reported cases of suicide in people who've reduced their opioids rapidly. There's also the issue of stigma and GPs withdrawing. So there's a number of GPs who are withdrawing activity. We have a number of active management approaches, which is from a safety perspective, and I think this needs to be promoted as a clinical group, that how do we maintain a large number of people on opioids as safely as possible and then gradually do motivational interviewing to work towards dose reduction. We've looked at some therapeutic drug monitorings, and I've had a couple of patients where we do a blood level and say you're at high risk, and we more rapidly dose reduce or do some inpatient detox for that high dosing. So I think the response is evolving. As clinicians, we will need to see both the benefits and the potential risks of a SafeScript system coming into play and the regulatory changes that are happening at a state as well as a federal level. So thank you for your attention.